Hello, everybody. I will present you the tricky clinical case of a 70-year-old man who had presented in 2014 an uncomplicated type B aortic dissection, and 4 years after, he presented persistent sepsis at Staphylococcus aureus after a urinary tract infection. And after several positive hemoculture, we perform a CT. You can see there. And my question, what is your opinion and what is your diagnosis? Wait a minute, because there is some details, interesting details down. Okay. So does anyone want to give his opinion of the situation for this patient?
How penetrating ulcer?
Penetrating ulcer? Not only, there's a little more.
Any intervention at all?
No. It was only medical therapy at first because it was uncomplicated type B.
Yeah, mycotic aneurysm.
He's, excuse me, sorry, I didn't hear you.
Mycotic aneurysm.
I didn't hear you well, but maybe mycotic, but yeah, he's septic. And you can see a collection there, the star, para-aortic. There is a false lumen, a true lumen, and there is a rupture of the false lumen. You can see the calcification, and you see nothing between. And for us, this was a false aneurysm, maybe mycotic, but at the beginning, we had a bacteria. It was a urinary tract infection. And we had the positive hemoculture. So Staphylococcus aureus, it's a germ. Okay, so now our question were is the false lumen perfused at the level of the rupture? Is the collection perfused? Where is localized the primary entry tier if you want to do anything? Do we have all the response? To our question, sorry.
We don't know because there's only one phase of contrast. So what we see in the false lumen may be thrombus, may not be thrombus.
Yeah.
Blood.
You have here is arterial phase, and this here is the temporal phase. It's pretty difficult, but we can localize the primary entry tier just after the ostia of the subclavian arteria at the isthmus. It's a classic situation. But for the perfusion of the collection, it's pretty hard to respond. So we perform an MRA. That's why we are here. We perform 2 sequences, 40 track in first. And after the Dixon, it was quite not a very good result for us, the 40 track. And why it's not a good result? It's quite too short. The daily we use 4 seconds, but we choose like that 4 seconds. It was too short to have a good evaluation of the false lumen at the level of the rupture. And we don't know what is the speed of the perfusion in the false lumen. Is it part thrombosed or no? So it was quite tough to determine which daily we have to fix. And we also realized a Dixon sequence. It seems the false lumen is perfused at the level of the rupture. The collection, concerning the collection, we don't have a good response. We don't know very well. But we also realize a 40 flow. And there we look a beautiful primary entry tear. Just after, at the first time, I thought it was a subclavian. It's so much beautiful. And after, we also the perfusion of the false lumen. And concerning the collection, we don't know very well. But we then analyze the flow. And with a measure of the flow, with marking here or I, and in the true lumen, in the false lumen, and in the collection. And we found quite the same in the collection and in the false lumen. So for us, the false lumen is perfused at the level of the rupture, and the collection is perfused at the level of the collection. So I would like to have your opinion at this stage. What will you do? Just he had antibiotic therapy at this level, but only that.
Immediately operation because stent is contraindicated because of infection.
Okay. Open and thoraco-abdominal transdiaphragmatic operation with a very high. It's very interesting because it's normally what you should do.
Or take a risk and stent graft over the entry tear,
Yeah.
which is remote from the site of infection, and hope for the best.
We choose to perform another prosthesis at the level of the primary entity to close it, because we hope it is not infected at this level, and we didn't do anything at the level of the rupture. Our opinion, our way, it was a bet, it was to close the primary entity to stop the perfusion of the false lumen, and it was a septic patient, so if he was too much septic, to drain the collection, but to drain the collection we have to be sure, certain, there is no more flow. So, our question is, after the implantation of the endoprothesis, is the first lumen still perfused at the level of the rupture? Is the collection still perfused? And can we drain it? Can we drain the collection? I will go back a little because you will see, I will make a pause. Yeah, my question is there endoleak? Do you think there is a perfusion there, just there, in the first lumen? We thought it's not a good result. We're not sure. Is it a perfusion or not? So we will I go down to the level of the collection, but we realize an MRI to be sure and to analyze the flow.
You don't have a delayed CT scan when you follow up a stent graft. You always
Yeah, it's a post-operative CT. This one.
yes, but a delayed 1 minute acquisition after this.
Yeah, I have it. I have it. We have the boss, and at the boss it was quite the same image. Okay. It's a portal. It's a portal. Okay. We perform the MRI, and at the with the MRI, we is a post-operative on the right. We don't see anything by the visualization, but if it's an endoleak, a low, we have to measure the flow. And we measure the flow at several points in the level of the descending thoracic aorta. And we didn't measure anything more than 64 milliliters per minute. For us, it's noise, because we measure it per second. It was around 1 milliliter per second, and after we multiplied it by the bit rate, so heartbeat, so it was quite noisy. It's noise. For us, you have a real difference between the two, pre-operative and post-operative, so you can drain it, and there is no collection. So after 8 months, there were still no symptoms under suspensive antibiotic, and you can see it was a misinterpretation for the post-operative scan, CT. There were obviously no perfusion of this false lumen, because you can see a decreasing diameter of the false lumen, and you will see at the level of the collection, there is no more collection. It totally disappeared. Without drainage. Finally, we wanted to be sure of the perfusion of the false lumen, because we said if it's too much septical, we drain it. But finally, the antibiotic and the endoprothesis closure were enough. There is no more collection at this level. So, as a little conclusion, the CT helped us to make a morphologic evaluation to diagnose the pathology, but thanks to the 4D flow, we have been able to realize the dynamic evaluation. And it's in our center we use very, very frequently the 4D flow for the dissection. It helps us a lot. Thank you.